All right, we can go ahead and get started. Welcome everyone. This is Leona Edwards. I'm the Administrative Assistant with CFHA. Welcome to another webinar. I'm going to hand it off to Stephanie to do some introductions and families and health SIG housekeeping. So,
all right, thank you. Welcome everybody to the August Families and Health webinar. Excuse me. For those of you that do not know me, I'm Stephanie Trudeau. I'm the current chair of the Families and Health Special Interest Group. Just before we start today's webinar, I have just a couple of house cleaning items that I'd like to talk about. First of all, I want to warn everybody that over the next week, you're going to be receiving a series of emails from me. I'm just returning from maternity leave and catching up. But we are currently actively seeking nominations for leadership positions for our SIG. The positions that we have open are incoming chair, we have an early career professional spot, and then also looking for a secretary. We are also going to be recruiting your expertise as we start to develop a culmination of online videos for early career professionals. And then lastly, there will be some information forthcoming about meetings and virtual network events that are going to be hosted during this year's CFHA conference. So house cleaning is done. I'm personally very excited about this webinar today. And today's webinar is titled Family Caregiver Stress, How to Measure It and Why. Our presenters today are Dr. Matt Martin, who is a clinical assistant professor at the Doctor of Behavioral Health program at Arizona State. And we also have Dr. Mindy McEntee, who is a postdoctoral scholar at the College of Health Solutions, also at Arizona State. The presenters would like to encourage a dynamic format. Please feel free to ask questions as they come. Go ahead and use the either raise your hand option or add your questions to the chat box. And I'm going to turn it over now to our presenters.
Hi, everyone. My name is Matt. Well, I'm very grateful to be here alongside Mindy. We're looking forward to sharing the work that we have been doing over the last several months, and we hope that that you'll enjoy this presentation and that you'll think of some questions or comments to make as we're sharing this information with you. So this is who we are. We'll have the slides available if anyone wants to contact us with other questions, or if you want to see more of this work, we'd be happy to share it with you. What we're hoping to do today is we want to talk about the rationale for measuring caregiver quality of life. We hope that we can make that case to you. We'll talk about some general properties for what makes an effective quality of life measure. We'll share the results of the systematic review that we did, and then we'll talk about some potential screening tools that you could use in your own work if you're a clinician, as well as talk about some potential research ideas for advancing the field. So let me first talk about why we even got into this project. This is not an area of expertise for myself, and so it's something that I was introduced to by a colleague of mine. A couple of years ago, I spoke to this colleague, and he mentioned that there were agencies and other organizations that were looking for a brief measure of caregiver stress, burden, quality of life, even a single item measure. And so I kept that thought in my mind for a long time. And then about a year later, I had an opportunity to do a fellowship with a psychometrician named John Ware. And so I was excited to connect with him, and I pitched this idea of trying to develop a brief or a single item measure of caregiver quality of life. As a clinician, as a mental health provider, I saw a lot of utility in having that kind of screening measure in primary care, in hospitals, and other kind of medical settings. So he and I talked about it, and I quickly learned that it actually takes a lot of technical skill to develop measures, especially single item measures. And so he recommended, Dr. Ware, he recommended that that I first start just looking at the literature, see what is out there, and put together a directory or a database of some of these measures, and then find some that are potential and see what I could do maybe to improve upon them. And so that's where this project came from. Many of you are certainly aware of the prevalence of caregiving. There are a lot of unpaid family caregivers, about 43 million here in the US, almost 1 in 5. And they spend about 24 hours on average, and 20% of them consider their role to be stressful. And about 17% would describe their health as fair or poor. So this is a large population, and it seems like there may be some risk or some health needs that need attention for caregivers. Here's some data from the CDC. Here you can see the percentage of caregivers 45 years or older who are reporting frequent mental distress. In my current state of Arizona, it looks like we're in the high category. We have about 17% of caregivers who are reporting mental distress. And then you can see that in the in the South and parts of the Midwest, there are also some other places with high percentages. Here's another map from the CDC. This is looking at, again, caregivers over 45 years of age who are reporting 2 or more chronic diseases. So again, we can see a lot of states where there are nearly 50% of caregivers who have at least 2 or more chronic diseases. And then finally, one more map from the CDC, and again, looking at 45 years or older, and these are reporting being a caregiver to a friend or a family member. And so this reflects the other data that we show, that showing that this is a pretty large population, that caregiving is fairly prevalent in our society today. So what seems clear from our review of the literature is that it's prevalent, it's demanding, it's stressful, and there's some early research that suggests that caregiving increases mortality risk for caregivers. There's a large study from Schultz back in 1999 that was just a landmark study. Well, over the last 5 to 7 years, there's been some more research coming out suggesting that caregiving might actually have some potential protective benefits as well. And so that begs the question, do we have a balanced and updated perception of informal caregiving? In other words, is our current definition comprehensive and sufficient enough? That's one thing that we wanted to discover. And so the logic that we have for this project is that if caregiver well-being, their quality of life, if that impacts patient health outcomes and the costs associated with their healthcare, then service agencies and healthcare systems really are incentivized to identify caregivers that need attention, that need support and resources. And this really depends on the type of technology that we have for measuring and identifying those caregivers. That kind of technology should be timely, it should be accurate and efficient. And it's not very clear if a single item measure exists out there that agencies and healthcare systems could use. It's also not clear what the quality and the feasibility of using some of these existing tools is as well. So the primary aim of this project was to identify brief single item measures of caregiver quality of life. And some secondary aims were that we just wanted to see what was the range and frequency of some of these domains. When I talk about domains, I'm referring to those dimensions of caregiver well-being, quality of life, things like physical health, mental health, vitality, social support, spirituality, financial, just a lot of different ways to look at how are they doing overall. And then another secondary aim was we wanted to see what other potential areas of research are there. So I'm going to turn the time over to Mindy, and she's going to talk about what makes a good measure.
All right, go ahead and click on to the next slide. So talking about measurement, Matt's talked about the focus of this being on caregiver quality of life. And caregiver quality of life, well, quality of life in general is something that's inherently subjective. And it's comprised of 2 components. So we have well-being and functional status across multiple domains. So physical, mental, social, all of these and how they interact together is what comprises quality of life. So why is this important? It's really key in being able to achieve the quadruple aim within healthcare. So researchers use measurements in order to better understand the underlying relationships between patients and their health, whereas clinicians are going to be able to use measurements for screening purposes, to be able to triage patient needs, monitor progress over time, and really be able to provide support to patients with those health needs. You can go on to the next slide. So what are we meaning when we talk about patient-reported outcomes? So the defining feature of these PROs, as they're sometimes called, is that you're using information that's coming directly from the patient via self-reported questionnaire, and there's no interpretation by a clinician or anyone else. So it differs from lab values or functional tests, which are more objective. We're just looking at the patient's experience as they report it and taking that at face value. Go ahead, Matt. So there's a lot of differences across PROs. They can be used to measure a lot of different areas. Quality of life is just one of those domains, and quality of life in and of itself is multidimensional. So across these different measures, you'll see a lot of differences in terms of the phrasing of these measures, whether they're using past or present tense, the period in which they're looking at assessing over time. So some of them can be as short as over the past week or over the past 24 hours, and sometimes it can go back to as far as over the last year or so. There's also quite a bit of variability in terms of response options. Most of them do tend to use Likert type scales, so either reporting how strongly do you agree with these statements or how frequently does this particular item apply to you. I think the most helpful piece to go over in terms of distinctions between types of PROs is the selection of generic versus disease-specific measures. So only the generic measures are suitable for comparing patients that are across conditions or disease groups. But the issue with that is that sometimes the item content can be redundant or it may not be applicable for all conditions. And you're not going to always be sensitive to catching disease-specific issues. So if you have a caregiver, for example, who is caring for somebody with dementia, they might encounter very different day-to-day experiences than somebody who is late-stage renal disease. If you have the opportunity and resources available, it's recommended that you go for a combined approach, combining the generic and disease-specific measures. But again, depending on the length and the resources that you have available, that may not always be an option. Another piece to look at is the scoring. So there are PROs out there which specialize in just providing an overall summary or index score. This is oftentimes really great if you're looking at something for a cost-benefit analysis, or if you're looking to provide an initial triage for somebody who might need additional support or resources that you're not going to be able to provide more nuanced support, but you're just looking for an initial first vein to direct them to. And if you contrast that with the multidimensional scoring, which provides you really a better profile of scores across domains. So, for example, looking at how psychological functioning is different from social functioning versus somebody's financial status. Typically, these measures that are multidimensional tend to be longer in length, so that is, again, another trade-off. And the recommendation here is really that you base off of what it is that you're trying to do at your particular clinical site. So I have on there, there's a difference in scoring. So some measures are population-based, meaning that they use norms that are based on a larger population. A trend in the PRO literature and the PRO work is really being able to provide individualized norms. So rather than relying on a population, they're looking at individual progress over time. The downside to the individualized norms is that they're not readily available across multiple domains, and they're not readily available for caregivers in particular at this time. Matt, you want to go on to the next slide? So PROs, why should we use them? PROs are becoming increasingly relevant as the field moves more and more towards patient-centered care and really being able to follow these value-based payment models. So patients have identified that quality of life is one of the most important outcomes for them. So anytime that you're able to include that as a measure and actually utilize that within clinical practice, it's something that tends to be valued by the patients. You're also facilitating the collaborative relationship between patients and providers. So this can be very empowering for patients. It can also help facilitate their involvement in clinical decision-making and really help the provider too to be able to develop a treatment plan that's able to accommodate patient preferences, culture, and individual values. Anytime this happens, then you tend to see an increase in the satisfaction that patients experiences, as well as better outcomes. And the literature on that is pretty robust in terms of both future health and both subjectively and on objective measures. So in terms of using the PROs from a clinical perspective, the utility is really coming from being able to increase the coordination of care. Quality of life is a really effective predictor of a number of different clinical, economic, and social consequences of health and disease, and has been shown to be a really strong predictor of future health, mortality, and cost of care. This is relevant for caregivers since we know that a lot of them themselves also have comorbid disease. The issue is, despite the fact that we know that PROs and quality of life is important to measure, we're really not frequently seeing this implemented within clinical care. And as Matt mentioned earlier, if we know that caregiver well-being and quality of life impacts patient health outcomes and costs, then there's incentive for agencies and healthcare systems to be able to provide additional support for those caregivers. Can you go on to the next slide, Matt? So as with any measure, there are limitations. With quality of life being subjective, we know we can't measure it directly. And so we're relying on patients to tell us their experience. And there are a lot of strengths to this, but there are also some limitations, namely that we're going to be subject to bias. So patients or these caregivers may respond a certain way to appease a particular provider, or if they feel constrained by time, or if they're stressed and they're just having a difficult time recalling over a certain time period. All of these things can contribute to variations in the way that caregivers respond to these types of measures. It should be noted that all measurement contains error, so PROs definitely, but all measurement in general. So there's no single approach to measurement that's universally accepted. The answer is always, it depends. So caregiver quality of life is no different, but it is worth noting that with PROs, there may be disparities between what you see in terms of clinical effectiveness or objective data and the self-reported data or the quality of life data. So what do we take away from that? Basically, this really reiterates the need for using validated measures and validated in the populations in which you intend to use them, and being able to use PROs to supplement other data. So use experience data with outcomes data, use the patient reported subjective measures alongside objective measures to really supplement your data as opposed to just relying on one or the other. Go ahead to the next slide, Matt. Thanks. So what are we looking for in terms of psychometric properties of these measures? I'm sure most of you are familiar with these or have heard them at some point. So reliability, we're looking for a measure that's going to be consistent. If we give it to them multiple times, are we going to be able to reproduce those results? Reliability often comes through, you may read it as a Cronbach's alpha that's being reported. So reliability is necessary, but not necessarily sufficient for high validity. So what do we mean by validity? Validity is just really referring to the accuracy. Is this measure capturing what it purports to measure? And caregiver quality of life is one of those constructs where it covers multi-dimensions and it can be kind of nebulous. So it's really important in this research and clinically that you consider and carefully evaluate what it is that you're trying to use these measures for. We also want to look for a measure that's sensitive to change. So something that's going to respond to changes within a particular patient. And this is really important the more that you're looking to measure change over time. Clinical relevance. the key here is that a lot of the research measures, or the measures that were developed for research, are looking at statistically significant differences, which may not necessarily translate directly into something that is clinically significant. So sometimes you might want to look and see if you can find a minimum clinically important difference, or an MCID, and that's going to give you a better indicator of what you're actually looking for to see a clinical impact within your patient population. And finally, the thing that I think is easy to forget sometimes, if you get so caught up in looking at psychometrics, is you really want a measure that's going to be actionable. Are the scores going to give you information that you can act upon? Are they going to guide clinical decision making? And is that clinical decision making something that you can act upon with the resources available to you within your specific clinical setting? You can go on to the next slide. So this really just kind of gets at, this is all a complex process, right? So there's multiple factors to consider when you're selecting a measure. You want to look for the evidence of reliability and validity, but you also really need to consider a lot of other contextual pieces within your setting, within your patient population. What is going to be the most helpful to you and your clinicians? You want to take it back from that, Matt?
That's great. Yes. Thank you, Mindy. So at this point, we'll talk about the actual results of the project. Remember that this was a systematic review of the caregiver measures of quality of life that are currently available. We did a search through CINAHL and PsycInfo. I found a very useful repository of tests and measures that was very handy to go through. The criteria was any study that was reporting the use of a caregiver quality of life measure. And we tended to focus more on those that were reporting psychometric properties and domains as well. We were specifically interested in the domains and how they were conceptualizing caregiver stress, burden, quality of life, those types of concepts. So after doing that search, we started to review. We did a screening of all the titles and the abstracts. We then did a full review of the full text, and then started to pull out data to put into our database, which is an Excel sheet. So we screened about 1,524 references, and from that, we have a final number of 96 measures. There were many measures that we cut out over time because they just didn't meet the criteria. So we have a final number of 96. So let's look at these different at the database. So here's a bar graph showing when each measure was first published based on our understanding. And the first one that we found was published back in 1983. And then since then, there's been a lot of other measures that have come out, especially within the last 15 years. There's been quite a lot of development in measures. And a lot of these were measures that were being maybe modified or tested in a new population, or these were measures for a specific health condition like brain trauma or cancer or palliative care, something like that. Here, this is a word cloud of all the different measurement titles. I thought this would be a helpful display to show what are some of the most frequent words that we found in the names of these measurements. And as you can see, of course, they were using the word caregiver, but also scale and family, and then also burden. That word was used quite a bit. In fact, at least 23 out of the 96 had the word burden in it. And then about 10% of them had, or around 10% had the word quality as well. So this is significant because, as we mentioned before, there's some research showing that caregiving has a potentially protective benefit. And based on at least the titles, so it seems that some of these measures may not be looking at some of the positive benefits. Here, this shows the different measures that are specific to an illness or measures that could be used for any illness. So for example, the generic ones are ones like the Zarit burden interview, the burden scale for family caregivers. These are ones that, that potentially could be used for any health condition. Whereas there are measures that are specific for things like delirium or traumatic brain injury. The health conditions that we found most common for these illness-specific attributions were for dementia, Alzheimer's, and delirium, mental health, and other similar conditions. We also found many of those for that as well. But overall, it seems that most of the measures were generic, that they could be used for any health condition. And then we also looked at, based on the reported domains or dimensions, in other words, how did they make sense of caregiver wellness, quality of life? We only found a few that looked at what is called the positive appraisal. In other words, what are those protective benefits? For example, is there something that is rewarding or satisfying about being a caregiver? Does the individual feel closer to their loved one? Do they enjoy the time that they provide care? We found about 9 measures that have this dimension. Things like the Adult Carers Quality of Life Questionnaire. So these were definitely a smaller group. Most of them did not measure any type of positive appraisal. Most of them were just looking at the negative impact of caregiving. So I'm going to go into some examples of the measures that we thought were potentially useful as being a brief measure in a medical setting. Here's one called the COPE. This has 15 items, and it has a 6-point response scale going from as high as all the time to no time. It includes mainly negative impact type domains, but there's one item that has a potentially positive appraisal. It has some fairly good psychometric properties. And here are the items in this one. So it asks things like, do you feel you cope well as a caregiver? The potential positive appraisal item is number 9. Do you find caregiving worthwhile? So it's kind of a weak connection to the protective benefits or positive appraisal, but it's more than a lot of the other measures have. So this one is nice because it has a nice range of response items. It's fairly short, it's around 15. We found that on average, most of the measures had about 20 items on average. There were some that had 40 items, 70 items, and then one that had over 200 items. Here's one that I really like. This is called the Caregiver Strain Index plus Positive. What these authors did, this was about 10 years ago, what they did was they took a fairly reliable and valid measure called the Caregiver Strain Index, and they added positive items. The original one has about 13 items, and they said, hey, let's start measuring positive stuff. And so they added 5 items that looked at positive appraisal. So the feasibility is good. There's some evidence that it's also valid. The challenge though with this one is that it's yes or no. So that's the only response items that are available. So if I were to give this to a caregiver, they can only choose between those 2 options. And I imagine that for some of the individuals, there might be a maybe, or there might be a sometimes yes, or sometimes no. So that kind of response scale can limit I think the power of that measure. But here in this example, you can see some of these positive items, like number 3, the individual or the patient appreciates everything I do for him or her. Number 6, besides the care I provide to my loved one, I have enough time for myself. Number 14, I am happy to care for so-and-so. And number 18, taking care for so-and-so is important to me. These are the kind of items that are uncommon in a lot of the other measures that we found, but I think are important for capturing the type of broad definition of caregiving that we may have to consider.
Matt, it looks like we have a couple of questions come in looking for feedback for any measures for multicultural populations, including English and Spanish. And then a second question, feedback about the WHO's brief quality of life measure, again, which is in the public domain and available in English and Spanish. Did you want to comment on that?
Yeah, I can comment on the different languages and cultures. So there are lots of versions of some of these measures that have been translated. In fact, this one, the Caregiver Strain Index, that one has been translated into a lot of other different languages. In terms of cultures, there is some research that suggests that some of these measures do not translate well to other cultures, which makes complete sense because some of them were developed for particular cultures by researchers from those cultures, and so they may not fully capture or represent the conceptualization of caregiving that is held by another culture. So I think we have to be careful when we transfer these measures from one culture to another.
Right, and if I can add to that, Matt, I think the other piece to keep in mind is that sometimes you will see, this is more often, I think, more common among the smaller, less well-funded studies, not necessarily the WHO's brief quality of life measure, but some of the smaller ones. Translation into another language does not necessarily guarantee that you're going to have that same representation of representing the culture. And so just be careful that it's validated within a group that is as close to the intended population that you want to use it with as possible.
Yeah, thank you. Thanks for those questions. Any other questions? Okay. So here's the last example that I'll share. This is probably one of the most well-known and oldest measures. This is the Zarit burden interview. The original was first published, I think, in 1983, although there may have been a publication in 1980. The original measure has 22 items, and over the years, they've been testing and developing shorter and shorter versions of it. Well, about 10 years ago, Higginson and his team, they compared all of these short measures. They compared 6 different short versions of the ZBI with the full measure, the ZBI 22. And they found that a lot of these brief measures of the ZBI were pretty good. The best one was the 12-item measure. However, the 7 and the 6-item measures also showed pretty good properties as well. And their conclusion was that the 4-item or the single-item measure could be used as a pre-screen or a screening tool. And then if that caregiver has a positive screen, you could then administer the full screen, whether it's 7, 12, or 22 items. The response scale is pretty good. It goes from 0 to 4. So there's a lot of variability in how people can respond. Here is the single item ZBI. The question is, overall, how burdened do you feel in caring for your relative? So there's some nice things about this. It's pretty brief and simple, straightforward. And again, it has that nice response scale. One thing that I've noticed about this, though, is that it focuses on the burden of caregiving. And so it doesn't include that opposite end of the spectrum, which could be some of the enjoyment, the satisfaction, the meaning that comes from caregiving as well. And clinically, one reason that might be important to measure is because this could potentially lead to a false positive. Maybe there's a caregiver who is definitely stressed, is definitely very busy as a caregiver, but they also find a lot of meaning and a lot of satisfaction out of it, and they don't need additional resources. They don't need to see a mental health provider, and so that individual may not be a good candidate for getting a positive screening and then going on to a full screening. So that's one reason why we may want to consider a single item measure that tries to cover multiple domains. So there's the one item, and then here's the ZBI-4, which asks those 4 questions. All right, we've started to look at psychometric properties. We haven't completed our full review. I will say that the ones that we have reviewed so far, it seems that most of them are reporting that their measures are reliable and valid, and so that's encouraging. There's just been a lot of robust research done in this area. So stay tuned for that. We don't have any conclusions yet, but the preliminary analysis shows that, yeah, most of them seem to be reliable and valid.
And one point that if I can jump in and contribute to that is the challenge is that there's a lot of variability in terms of what each of these measures are supposedly assessing. So subtle distinctions in the construct that's actually being measured. Caregiver quality of life is still pretty nebulous. There's no universal agreement on what are the absolute key domains or what is the kind of limitations of assessing that. And so that contributes to some of the challenges in selecting a measure and trying to make sure that the measure is valid for a very wide population.
Yeah, thank you. Okay, so we'll move into the summary and implications. I'll do a summary and then talk about potential next steps, and then I'll turn the time over to Mindy to talk about some more next steps. So in all, I was just so impressed with the literature. It's big. There's been so much work done in this area, and not just in the US, but in multiple other countries. There are many talented, experienced researchers out there that are trying to figure out how do we develop really good measurement technology for caregiver quality of life. And it also seems that over time, there's been more consideration for other dimensions besides just burden and stress, things like that. We saw that most of them are generic, so they could be used for any type of health condition, whether it's stroke, Parkinson's disease, or whatnot. Most of them up to this point do not measure the potential benefits of caregiving, or at least the meaning that comes from it. And most seem to have promising psychometric properties.
We do have another question, Matt, asking if we're going to be publishing or can share the list of the 96 measures that we were reviewing.
Yes,
you want to comment on that?
I think we're going to wait until we publish the first manuscript. But yes, eventually, yeah, we'll be happy to share that with the public. I don't think we'll share it with anyone here right now. We're looking to finish cleaning it up and then publish our first manuscript. Okay, in terms of implications, like I mentioned before, I think there's a lot of value in having some type of pre-screening or screener question. If there's a clinic that wants to take a universal screening approach and they want to screen every caregiver, every family member that comes through the door, I think that's okay. I think one thing that will help them to manage that type of workflow is to have a single item measure. And this is something that I think has been used for other measures, like for depression or alcohol use. There are pre-screen questions. So for example, the PHQ-9, there's actually an item at the end of the PHQ-9 that asks, you know, how bad have these problems been? That's not the exact wording, but it's basically actually asking what kind of an impact have these symptoms of depression had on you over the last 2 weeks or so. And sometimes that question gets missed. It's not asked of the individual, but that's actually I think a fairly effective pre-screen question that could be asked. The audit also has some pre-screen questions about alcohol use, and so These types of single item measures are helpful for identifying people that would qualify for a full assessment, or at least a fuller measure. In terms of research, it seems like there's more that can be done to test the effectiveness and feasibility of these single item measures. After we discovered the ZBI-1, the single item measure, I did a search to see if anyone had tested using that in primary care or hospital settings, and I could not find any studies yet, which was surprising. There's been a lot of studies looking to see how well it correlates with other measures, but I think there's more that we can do to determine how can these things be used clinically. Okay, Mindy?
Sure. So one of the things that we talked about, initially is this issue of breadth versus depth. We know that no one has a lot of time to be able to complete these measures. And we also know that from an assessment perspective, we like to have more information. More information tends to be better. We feel like that's going to help us make these decisions. So the challenge in trying to select a measure, both for developing something that has strong psychometric properties and in picking something that's going to be pragmatic for a clinical setting, is trying to find this right balance. So what Matt had suggested about using a single or 2 or 3 item max as a screener is one way of approaching this. And generally that tends to be the way that a lot of folks have gone, just because you are identifying the people that are at greatest risk for needing additional services, and you're not spending as much time or requiring as much burden from those who may not need any additional services. So there are some ethical considerations as well. I would ask, if you are looking to screen somebody, that you at least assess whether you have the resources internally to follow up if there is an identified problem. I think that is something to think about. That's a question that's been brought up from the perspective of screening for other mental health issues in primary care, for example. If you don't have the resources to be able to provide somebody who screens positive for depression with therapy or medications or any sort of follow-up treatment, what is the utility of that screening? I think the same thing applies to screening for caregivers. And so to be able to consider what are we really looking to do here? Who are we trying to help? And what specifically can we do for people that score above whatever our threshold is? What resources do we have? And is that sufficient to be able to try and address these patients' needs? So if you are in a position where you're looking to select a measure for a particular clinical setting, here are some considerations that you might want to take in mind. Intended purpose, really thinking about, are you looking for an initial screener to identify people who might need a one-time referral, or are you looking to monitor progress over time? Is this something that you want to assess, caregivers every year and see how they're doing relative to where they were previously? And then again, this issue of validation for the population that you are actually going to be using the measure with. That's sometimes really challenging, especially when you have like I'm thinking of an FQ that I work with that has a lot of undocumented folks and uninsured people. It's pretty tough to try and find measures that are validated for that specific population. So again, you can take a best guess based off of the research, but keeping in mind that there are still considerable gaps that remain in being able to find something that's going to be perfect for your patient population. Finally, being able to consider, are these scores or whatever measure that we do select, is it going to be useful for us? What are we actually going to do? How is this going to be implemented in a clinical decision-making process? Do we have the necessary resources to be able to send people to somewhere to be able to get additional resources if they are identifying that they're struggling? Or is this something that we need to think through further before we actually implement this process? One final note, PROs in general tend to work best when the issue or the construct that they're assessing is a high priority for the clinic. So if this isn't a high priority issue for you, that may be a sign that PROs may not be that beneficial, or at least in this specific domain. So just a final consideration. Just be thoughtful, be mindful, and evaluate your options. And it may take a little bit of piloting to be able to figure out if something's going to be effective for your patient population.
Okay, those are our references. Thank you all for attending. We hope that this has been helpful. Are there any questions? We have some time, so if there's any comments or questions, anything that anyone would like to discuss, we'd be happy to discuss it.
Matt, I do have a question. Within your review, what measures did you find that were specifically trying to find those positive outcomes, you know, on the opposite side of burden? So the meaning making, you know, possibly some post-traumatic growth, anything like that. What did you find?
So we did find some measures that wanted to add that positive appraisal. I can't think of any patterns that we found among them, except that maybe they seem to have come out over the last 10 years. And I would suspect that some of them may have been inspired by some of the research that has come out showing that there are protective benefits for caregiving. But the items that I have seen in those measures, they seem to be measuring just the meaning, the satisfaction, the enjoyment, the fact that they're spending more time together, that they feel closer together, those types of items, which I think when I think about my own clinical experiences with patients who have done caregiving, I think that really helps to reflect the broad experience of caregiving. So I think those kinds of measures are headed in the right direction. And I think that's also parallel with other quality of life measures that are becoming more sophisticated and becoming a little bit broader. So instead of looking at just depression and sadness and fatigue, some of the more modern measures are looking at vitality, at looking at happiness, at satisfaction, and I think becoming a little bit more sophisticated.
Looks like we've got another question, looking for recommendations for resources related to integrated behavioral health care and specialty medical practices, including the quadruple aim for healthcare.
Well, that is a great question. It's a broad question too. Marie, is that specifically related to caregivers? It looks like there's a follow-up question. Oh, no, this is a comment. So I don't have any recommended resources, at least for caregiving. Mindy, do you have anything to recommend?
For caregiving broadly, not so much. So there is the compendium of caregiving assessment that has been put out. The name of the organization that put that together escapes me at the moment. But to your point, Marie, I agree that the importance of involving family as caregivers in the health education, skill building, and interaction is incredibly important. And all of these things are overlapping and interacting factors. And it's been a real challenge for measurement to be able to keep up with that, and also for clinical guidance to use measurement tools as they come within the normal workflow of the day-to-day clinical operations. And that continues to be a challenge. And so there's been a general increased push towards using the single item measures. And I think that they're working towards that within the measurement sphere. They're really looking at trying to use single item measurement tools for each specific area. So even if you have a disease specific, it's the same question, but it's just applied to that specific condition. So that's kind of the direction that this is headed, but it's not quite there yet, especially within the realm of caregiving specifically. You see it more validated within the realm of health-related quality of life, but again, that's kind of getting away from your question about the resources related to caregiving within IBH specifically?
Thank you for that question. Any other questions or comments?
Looks like one more. Are any of the quality of life for caregiving measures reviewed in the Medicare MIPS in health settings versus mental health?
That's a good question. I don't know the answer to the Medicare MIPS. From what I've seen so far, no, I don't recall any of them. Yeah.
I don't think so either. Maybe at most one or two, but I'm not recalling any off the top of my head that are included in that.
Mhm. As far as for health settings or versus mental health, it seems that most of the measures have been developed to be used in any kind of setting, whether it's a service agency or a healthcare system. Some of them do include specific questions for mental health, but that's more of a domain question, more of a domain point.
And not related to use, but related to validity and predictive utility of these measures, quality of life tends to be more reliable as a predictor for physical health outcomes than it does for mental health, just because mental health tends to have a lot of other additional interactions that compound it. So that's kind of where measurement is at this point.
Yeah, I've really come to appreciate how much skill it takes to create these types of measures. I mean, there's a whole field of science that is devoted to creating accurate, effective of measures. But when I think of caregivers, they really face quite a wide variety of consequences isn't the right word. That a big part of their life is impacted by caregiving. They're suddenly having to navigate the healthcare system, working with insurance companies as well as providers. They have to know a lot about prescriptions and about whatever chronic disease they're trying to help manage. There's really a lot that they have to know and to navigate. And so it seems like our measures should be able to should be sensitive to all those areas of their life that are being affected.
Yep. And especially given that, you know, the data that you presented, Matt, that talks about how widespread chronic comorbidities are within the caregiver population, it may make sense to do something like the health-related quality of life, the generic health-related quality of life, plus a single item caregiving measure. So you're capturing both sides of that piece. You're not just identifying a patient's quality of life as affected by caregiving, but you're also acknowledging those other factors that are likely contributing to issues that may be at play.
Okay, I think we're coming toward the end. Stephanie or Leona, should we pass it back over to you?
Yes, thank you so much. That was a great presentation. And if there aren't any more questions, I hope everyone has a great day. Thank you so much to you both.
Thank you.
You're welcome.
Thank you.